So the topic that we are going to talk about today is IVF and fertility treatment for women over 40s. What are your chances? I think it's a quite interesting topic, and I'm sure that you will have many questions that I hope to be able to clarify after the presentation. So first of all, what will we cover? So we are talking to talk about advanced maternal age. What's the definition of that? The consequences and the different treatments that we can offer our patients in their 40s. So first of all, let's try to define what we call advanced maternal age. So it's typically defined as getting pregnant at 35 years old or older. So we know that at that age and also older patients may have decreased equality and also a reduced ovarian reserve. And it happens when age increases. Apart from that, we know that the age may increase the chance of carrying a baby with chromosomal disorders such as Down syndrome. In addition, it's also important to note that age is also related to increased fetal risks such as miscarriage, stillbirth, and abnormal growth. And of course, maternal risks such as high blood pressure, diabetes, and premature birth. Those risks are even higher in twin pregnancies. So that's something that we should consider. We will talk about the single embryo transfer in the following slides, but it's important to know that those risks would be even higher in twin pregnancies or in the end multiple pregnancies. So in this slide, you can see the consequences of the advanced maternal age. So in this picture, you can see that that ovarian reserve, antral follicle count, and the AMH decreases as age increases, right? So, however, the FSH, which is a hormone which is produced in the brain, will also start increasing. So you can see quite clearly how the age may have an impact in terms of the antral follicle count, the ovarian reserve, and also in the AMH. So in the end, it may affect the result of trying to get pregnant naturally, and also the result of the upcoming treatments. It's also important to see how the increased maternal age can also have an impact in terms of the aneuploidy, the chance of having healthy embryos, right? So you can see in this slide how maternal age has an effect in terms of the percentage of aneuploid embryos we expect at the laboratory. And it also has an effect on the miscarriage rate and also in the live birth. So you can see how the live birth starts decreasing as the miscarriage rate increases and also the aneuploidy also increases. So that's something very important to consider for our patients and to give that like the most proper information to them at the consultation. So we were saying that the advanced maternal age may have some consequences, and now we are going to talk a little bit about the potential treatments and the different options we can offer to our patients. The first one, which is the most common one, is the in vitro fertilization treatment, the IVF treatment. So in this slide, you can see how the IVF treatment works. So normally we start the treatment is stimulating the ovaries. So we use some medication to try to push the ovaries work as much as possible. And then we always do some scans, some ultrasounds to monitor how the follicles are growing. Then after knowing how the follicles are doing, we schedule what we call the egg retrieval, which is the procedure by which we are taking the eggs from the ovaries, right? So that procedure will be done under sedation, which means that the patient needs to stay in this case, in Madrid, at least for one night to make sure that she's doing good enough. Then the eggs that are retrieved at that procedure will be fertilized with a sperm sample. It doesn't matter with the sperm donor, with the sample from the patient's partner, and then we will create the embryos. So during 5 days, they will be in the laboratory. They will be under the control of the biologist, and they will check how the embryos are developing day by day. So in 5 days, we are normally able to have embryos to transfer or to do further techniques. So when we talk about IVF, It's true that I would say that in more than 90% of the treatments, we prefer doing the what the ICSI technique, which is called it stands for intracytoplasmatic sperm injection. So, and that technique is an IVF procedure where a single sperm cell is injected into the cytoplasm of a mature egg. So, first of all, we need to retrieve the eggs. Then we do what we call the accumulation of the eggs, which means that we remove the cells from the external part of the eggs. Then they will be fertilized. And if we want to microinject the eggs, it means that we need to prepare the egg first, and then we need also to prepare the sperm, and then we put them together. So we microinject with a very tiny needle. Then sperm we insert it inside the egg to see how they fertilize. Then in this slide, you can see how all the different stages of the embryo's development. So in the first one, we see how the embryo or how the eggs fertilize. We can see like the signs of fertilization. Then in a day two embryo stage, we see how the cells are dividing. And then day by day, sorry, we can check how the cells are dividing, and the embryos can be also classified depending on the quality. Finally, the embryos reach what we call the blastocyst stage, which is day 5 or day 6 embryos. And in that way, we see that it's a very different embryo from the previous stages. So we can select different parts. The lowest one is called the innermost cells that will be innermost cell that will be the baby in the future, and the external part is called the trophectoderm that will be the placenta in the future, right? So with that kind of embryos, the chances of implantation are higher. So we know that those embryos are like more viable than the previous stages embryos. So that's the reason why we always wait for 5 days to see how the embryos develop as a laboratory, to be able to select the best quality embryos. And also, this is the moment when we can perform one of the tests that we normally do in advanced age patients, which is the PGTA, right? The pre-implantational genetic screen, and we'll talk about that in the following slides. So we were saying like some minutes before that it's important to do what we call the single embryo transfer in blastocyst stage. So we were talking about the risks that a patient is taking just because of getting pregnant in older moments in older age of the life. So it's important to select the best quality embryo, and if we want to do that, it's important to try to transfer embryos on blastocyst stage. So we try. Well, I would say that we always avoid transferring embryos on day 2 or day 3. That's something that comes from the past. So when I started working at Clinica Tambre, it's true that in the past we did it many times, but now I don't remember the last time I did an embryo transfer on day 2 or day 3. It's like something from the past, as we are able to select the best quality embryo on blastocyst stage, and in the end it gives us like higher chance of implantation, which is what the goal we have. So we know that around 50% of the eggs that were fertilized will reach the blastocyst stage. I mean, that's a data which is completely like viable. It doesn't mean that it's going to happen to all patients, but roughly speaking, we calculated that around 50% of the embryos that start the development will end being blastocysts. Of course, not all of them would have the same quality, but at least it's something that we normally try to explain to our patients to have in our mind what we may expect from the technique. Then I would also like to talk a little bit about the pre-implantational genetic screening. So we were mentioning before that age may have an impact in terms of the egg quality, the egg quantity, also the chances of having healthy or euploid embryos. So the pre-implantational genetic screening is a test that can help us in first selecting the healthiest embryos to transfer. So what we do is that we do exactly the same procedure from as we are explaining in the for the IVF treatment, and then the main difference is that instead of transferring an embryo at that time, we do a small biopsy in the external part of the embryo with the idea of taking some cells from that external part of the embryo that will be tested. So in that In those cells, we are able to check the chromosomes, and we will transfer just the euploid embryos, of course, with the idea of increasing the implantation rate and the ongoing pregnancy rate. So in the end, when we transfer those kind of euploid, I mean healthy embryos, it's true that the single embryo transfer is highly recommended. Those embryos have a really high implantation rate. Apart from that, it's known that it may reduce the risk of having a miscarriage, because in many occasions, what happens with the miscarriages is that the main reason to have a miscarriage is the embryo itself. If we are transferring an embryo without having tested that embryo, and of course the patient is in their 40s, the chances of having non-healthy embryos are pretty high. So the main reason to have miscarriage could be the embryo itself. So we want to reduce that miscarriage rate as much as we can. Doing that pre-implantation genetic screening may help us in achieving that goal. Apart from that, it also reduces the duration of the treatment and the number of cycles needed, because in the end we are just going to do the embryo transfer with the euploid embryos that will increase that patient's implantation rate. So in this slide, you can see the success rate with IVF. So if we start in patients older than 35 years old, the implantation rate is pretty high, so around 62% according to our data, and it starts reducing as the patient gets older. So you can see that when the patient is older than 39 years old, the implantation rate is also starting to drop. So we calculate that around 42% of patients will get pregnant. But it's important to note that if we add the pre-implantation genetic screening, the PATS technique, the success rate will be higher, right? Because as we were mentioning before, one of the main reasons why the embryos don't implant, or why a patient may have a miscarriage, could be the embryo itself. So the idea is that we can try to maximize the options of using that all the options to get pregnant to that patient if we add that pre-implantation genetic screen. Of course, it doesn't work to all patients, but we are talking a very special group of patients, which is the advanced maternal age patients, in which we know that it may be like an increased rate of non-implantation because of the embryos factor. So when the first, let's say with first stage treatment doesn't work, or when we have like many like different failed attempts, we should consider another option such as egg donation. So the USRE in 2017 defined the egg donation as a fertility treatment for women unable to produce their own eggs, or at risk of at a high risk of transmitting a genetic disease. So the genetic eggs are fertilized with partner or donor sperm as a conventional IVF treatment cycle, and one or two can be transferred as an embryo for pregnancy. So the main indications for egg donation is, first, of course, the premature ovarian failure. So when the patient doesn't have the menstruation anymore, the ideal option would be egg donation. Then, and it would be like the majority of patients, failure of IVF treatments, and normally they are like related to low quality and low quantity of eggs, and normally they are caused by age, right? Of course, there could be other factors, but in most occasions we have like patients with failed previous treatments that the only option to get pregnant after those failed treatments is egg donation. Of course, some hereditary problems that cannot be diagnosed by the pre-implantation genetic screening also is a good group of patients that needs to be also well to undergo egg donation. And also, and last of the main reasons is like some medical conditions that may affect the ovaries, such as chemotherapy, or also endometriosis. In certain cases, those patients should undergo egg donation as like the treatment that will give them the highest chances of implantation. So when we talk about egg donation, it's a quite like easy procedure to follow. It has like two different parts. the part that is from the donor and the part that will do the patient. So the part that we do the donor will be an ovarian stimulation quite similar to the one that the patient has undergone in the past. Apart from that, we need to select the best or the most suitable donor for each patient. So the selection, at least in Clinica Tambre, is done in two different steps. In the first one, we consider, let's say, like the most general characteristics of the patients, such as skin color, hair color, eye color, let's like the most general characteristics. And then after having done the first selection, we use a computer program called Phenomatch that makes like a facial biometry to know the distance between your eyes, the kind of nose. The idea is selecting the most suitable donor for each patient. So in Spain, donation is always anonymous. So it's not possible to choose like some characteristics of the donor. And of course, the patient can't know who the donor is. And of course, the donor won't know who the patient is. So the idea is that first we select the donor. The donor will do the ovarian stimulation as a normal IVF, and then the idea is that the patient will also prepare the uterus for that embryo transfer. So in the end, we are creating the embryos at the laboratory exactly the same as we do for the normal IVF, but the main difference is that the donor, I mean, the patient will do an ovarian, let's say like an endometrial preparation to have the uterus in the best conditions possible, right? So after having that endometrium in the best conditions, we will do the embryo transfer. So normally the treatment that the patient is following will last for 3 weeks, roughly speaking. And then after having the endometrium ready, the idea is that the patient will undergo the embryo transfer exactly the same as she may have done before in the IVF trials. So in this slide, you can see like the main difference in terms of the success rate. So in the first part of the slide, you can see that even though the implantation rate with the patient's own egg start decreasing as age increases, you can see that the egg donation treatment has almost like, and I would say all exactly the same pregnancy rate and implantation rate, and is not being affected by age. So in this way, it means that even though maybe the patient is not having maybe the menstruation anymore, it doesn't affect the implantation rate because we are using young eggs coming from young patients. So in the end, the implantation rate and the potential of pregnancy with that embryo is much higher. So you can see in this slide how the implantation rate with donor eggs are always the same. It doesn't matter the age of the patient, but of course, also important to know that even though the implantation rate is the same, the risks related to to the pregnancy could be like starting increasing as the patient gets older. I guess that you all know that it's not the same getting pregnant when we are 40 years old than when we are close to 50 years old. Of course, the risks could be increased because of the age factor. So we should also considering trying to get pregnant as soon as possible, and of course doing a single embryo transfer. I mean, the risks that a patient is going to take because of getting pregnant in almost their 50s. If we add that risks to the twin pregnancy risks, it could be quite we are like facing quite an important problem, right? So we recommend transferring just one embryo, especially in older patients. And in the last picture, you can see like also the implantation rate, depending on how many attempts, I mean, how many embryo transfer the patient is doing, right? So in the first attempt, we calculate that it would be around 71%. And there is something called cumulative implantation rate, which means that as the patient does more embryo transfer, in the end, the implantation rate will be increasing. And finally, as a conclusion, I would like us to give you like some 3 or 4 basic ideas to take home. So first of all, it's important to do like an accurate diagnosis and a specific test. They are absolutely essential for a correct assessment, right? So of course we know that age is a factor, but it's not the only factor we should examine it. Apart from that, it's important to do examination in both male and female factors. And as we were mentioning before, the IVF plus the pre-implantation genetic screening may help increasing the implantation rate, reduces the miscarriage rate, and shortens the time to get pregnant, selecting a chromosomally healthy embryo to transfer. Egg donation may be the solution for many patients after previous failed attempts, IVF attempts due to age, low ovarian reserve, or low egg quality. And finally, in advanced maternal age, patients selective single embryo transfer is recommended to reduce risks during the pregnancy. As we mentioned, prematurity, preeclampsia, diabetes, and so, especially in egg donation treatments. So thank you very much for your attention, and I'm open to answer all the questions you may have.
Thank you so much indeed. Thank you for your thorough explanation and all the steps that need to be taken as well. And of course, now your favorite part, as always, we will go for your questions. So if you haven't asked anything yet, go ahead, type this in the chat section. Dr. Marban is definitely right here for you and will answer your questions. And there are some questions ready. So let's go ahead with them. And the first question is here.
Mm-hmm.
Well, look, we have some details here. I'm 49, about to do my fifth donor IVF cycle with third donor. First cycle resulted in chemical. BMI was over 30 for all cycles. The cycle will include ERA test. Would you recommend hysteroscopy at the same time as ERA test? I am on medication for hypothyroidism and have one ovary and blocked fallopian tubes. I have gone through menopause but have been on progesterone for 3 months. Any advice you can give to increase odds of success? Thank you so much.
Well, I think that in this case, from Lisette, it's a complicated case. So I think it's not as easy as just undergoing maybe an hysteroscopy and the ERA test. So I would suggest a hysteroscopy for sure, or a 3 dimensions scan, which is a scan to like perform like a reconstruction of the uterine cavity. Apart from the ERA test, I would suggest also doing some other further tests such as Emma and Alice. So it's like the, well, we call them time and meta. So they are like the test we use. But in the end, is to have like a good assessment in the potential clinical infections that the uterus may have. Apart from that, um, I guess that, I mean, as is doing egg donation, I guess the embryos would be good quality embryos, and at least it would be at least advisable to also have some kind of consultation with an immunologist to know if there is any kind of clotting factor or immune system factor that can also be playing a role. And finally, I mean, maybe I don't know if the sperm quality was also checked and if they were like any concerns about that. If so, maybe like doing the pre-implantation genetic screen on the embryos, it could be also one option. But I mean, in this case, I think that after so many failed attempts, I think that we at least should recommend like further examinations.
Okay, thank you. And there's a follow up actually from Lisa that I will go straight to this question and we will go back to the previous ones. So, none of the embryos were tested in my donor cycles. I have two 6BB embryos left. Would they be considered good to transfer?
Yeah, I mean, the 6BB embryos are good quality embryos, of course, and we expect that at least one of them is healthy. I mean, the chances of having healthy embryos when we are talking about egg donors, I mean, it's pretty high, but in the end, you never know what kind of embryos you are transferring unless you check them. And in this case, I mean, it's a very special case. Of course, it doesn't happen to all patients because the implantation rate is pretty high. But as I mentioned, in this case, things seem to be like not so easy. That's the reason why I was like considering different options.
And I hope that helped. Of course, if there are any other questions you wish to ask, go ahead, type this in. And we will now go to our previous question and different patient here. So I would like to ask about immunological treatments for elevated NK cells and cytotoxic cells. What is your opinion? Is it complementary to use with cyclosporin? What are your thoughts on Humira? Would you consider it?
Well, At least at Clinica Tambre, we don't use any of those treatments, right? So we have an immunologist who is specialized in immunological disorders related to reproductive issues. So in that way, the most common treatments he normally uses is like prednisone, sometimes also hydroxychloroquine, heparin, aspirin. So he combines all of them when it's needed, or if there's a special case, he decides what is the best treatment in this case. But we don't normally use cyclosporin and that kind of treatments, at least in our
Hmm.
clinic.
Okay, and there was actually another question, but I guess in this case you also don't use it, right? So it's complementary to use
Yeah,
cyclosorpin with prednisone,
I
right?
mean, we don't have any experience with that. I'm
Mm,
afraid. I mean, I'm not an immunologist, so I can't answer that question. I mean, that's
of
something that
course.
depends on the immunologist, unit.
Okay, thank you for that. Okay, another question, a little bit of a different method, right? So, what do you think about mitochondrial transfer technique?
Well, actually, something that is not like it's like a starting to be like used. So it's nothing that we are using in our daily practice. Yeah, in our daily practice. So in the end, of course, at this moment, at least in Spain, we are not using that technique, and maybe in the future we'll have like major, like data, and we'll start doing it. But for the moment, I mean, we are not using it
Of course, this is still experimental, and I don't think it's done
completely.
in Spain at all, right? At least at this point.
Exactly.
Okay, thank you for the clarification. And let's have a look at Talia's question. I'm 45. I just did my third IVF cycle with donor eggs, which all failed to implant. No PGTA on any of the embryos. I have had my own children in the past and had every screening test that could be done, and my doctor still does not know why the embryos are not implanting. Would you recommend picking a new donor or using a fresh cycle instead of frozen eggs?
Well, it's true that the implantation rate with rows like egg, so frozen and fresh eggs are almost the same. So I don't think that the issues the way the eggs are. So maybe, I mean, I guess that patient Talia has already done like all the research in the uterus, and so in that way, of course, I don't know how many embryos she transferred total, but maybe would be like an option like doing the PGTA to all embryos. And apart, I guess that she has done all the research that has to be done. I mean, the uterine one, and also like the window of implantation one, and also the immunological test. I guess that she has done everything. So in that way, if she's starting a new round, I would suggest maybe doing the PGTA to the embryos.
Okay, thank you for another advice. Talia, is there, if there's anything else, of course, you know what to do. Let's get to the next question. And sorry, just give me a second. Here it is. So, Anna would like to know, I'm 40, have AMH of 0.07. My clinic is not advising IVF. Anything you
I
can
mean,
advise?
it's true that it's difficult to say no. So it's true, and it's something that Anna should know. So the chances of success with such conditions in a patient who is 40 years old and with such a low AMH level are not exceedingly high. So in that way, it's true that of course she can try once, and of course I will suggest doing the PGTA if something, if there are like eggs at the egg retrieval and so. But it's true that we should be like quite transparent with our patients, and to be honest, I think that the chances of getting pregnant with such conditions are not very high. Of course you can try, why not, but it's important to have in your mind that maybe you should consider a different option if that first option doesn't work.
Okay, makes sense again. Thank you for that. Let's have a look at next question here. I'm 44, looking to go for IVF soon. My period stopped a year ago. Any advice for successful IVF?
I mean, if Ari is not having her periods anymore and as she is 44 years old, I wouldn't suggest undergoing IVF with her own eggs. Of course, I would suggest doing egg donation so the ovaries are not working anymore. In that way, it's not possible to stimulate them. So I would suggest, just doing egg donation then. Yeah.
Mm, okay. And actually, there is another question right after this from the same patient. So, is fresh embryo transfer better than frozen?
Well, I mean, the data that we have at this moment say that the pregnancy rate with fresh and frozen embryos is almost the same. Actually, at Clinica Tambre, we normally freeze the embryos in advance when we are talking about egg donors, right? So we freeze the embryos in advance, and then once the embryos are ready, we start doing the embryo transfers. We think that it's like much less stressful for our patients, and in the end, the results are almost the same.
Okay. Again, thank you so much for clarifying that question. Vanessa has a different question here. So I'm 44, 43, without health conditions, sorry, don't smoke, don't drink alcohol, but have AMH of 0.216. My husband analysis came out good. I want to use my own eggs. The doctor estimate he should be able to get from 5 to 6 eggs based on ecography performed. He advises to transfer on day 3 at least 2 embryos. Is there more chances to be successful this way?
I think that it would be exactly like the opposite. So transferring the embryos on day 3 won't give us enough information first to select embryos and then to see how many embryos are like viable in the end. So we know that from day 3 on, the sperm part starts like being like active. So if something happens between day 3 and day 5, we won't be able to see them to see it. So in the end, what we recommend is waiting for 2 more days and trying to do the embryo transfer on day 5 if possible. Apart from that, uh, like of course, it's something is like one thing is like knowing how many follicles they can see in the ultrasound that they perform, but it's likely that not all the follicles will grow, and of course not all the follicles will contain an egg. So first we need to see how many eggs we are able to retrieve. Then I would suggest like waiting for 2 more days and doing the extended culture to have the emerson blastocyst stage. And of course, one option would be also doing the pre-implantation genetic screening. And it's also possible to do what we call the dual stimulation, in which we do the first round of stimulation, we retrieve the eggs, and then 5 days later, we start a new round of stimulation with the aim of doing like 2 rounds of IVF in just in one menstrual cycle. And in the end, we're able to have like better, like a higher number of embryos potentially to be tested.
Okay, again, thank you so much indeed for yet another advice. Hope that helped again. And let's have a look. There are questions regarding the mitochondrial transfer, but as Dr. Esther already mentioned, this technique is not used in Spain. Someone is suggesting it's done in UK, but I guess this is something that we cannot
Yeah, it's
right.
true that in certain cases,
Mhm.
it's doable, but at least in Spain, as far as I know, it's something that is like not being used as a routine technique.
Of course, that. Thank you so much. So there, we had a webinar. It's also done in Ukraine. We had a webinar on this. So if this is something that you would like to get some more details, please get in touch with me. I will put my email address in the chat, and I can always send you the link. You can have a look at least at this past webinar. And let's get going. There are more questions coming up. If there are some other questions you wish to ask, go ahead, type this in. Christine has some details to share here as well. Because of my AMH, a low AMH, I went through 3 cycles of mild IVF collecting 1-2 eggs each time, which didn't result in any blastocysts, suggesting the issue was the egg quality. Having spoken to another clinic, they have suggested going with regular IVF to see if they can yield better egg numbers while still managing expectations around my chances of live birth, currently around 5-10%. What is your opinion?
I mean, in this way, it's true that they have tried in a certain way. So maybe like trying like a normal IVF round, it would also give that patient like higher chances. So as I was mentioning before, when we are talking about low ovarian reserve patients, and of course, if they are planning, I don't know if it's the same patient.
Sorry, it is the same patient,
Ah,
so
okay,
she
perfect.
provided
Yeah, if they are
some
planning
details.
to do the pre-implantation genetic screening in this group of patients, it could be an idea to do the dual stimulation as I was planning before. So in the end,
Mhm.
I mean that patient has already done like a mild stimulation that works quite well in a certain group of patients, but now maybe it's time to try to push your ovaries a little bit more, Christine, with the idea of trying to get as many eggs as possible. Of course, I mean, it would be one other option. And I mean, in the end, we are trying to maximize your options. You have done, like a mild stimulation cycles. Maybe it's time to try to like use higher doses of medication to try to push your ovaries work as much as possible. But I think it could be an option. Why not?
Brilliant. Thank you so much again for your advice. Christine would like to say thanks for that advice here as well. So I believe it was helpful. Thank you so much indeed. And I'm just looking out because there are some more things coming up, but I don't see more questions. So if you have more, go ahead to type this in. If not, we will be finishing for today. But remember that if there are any questions that you still wish to ask and wish to receive some more details, you can also get in touch with Clinica Tambre directly, and I'm sure the team will be happy to help you out. Someone is typing, so of course, let's wait and make sure that we've answered all of your questions today. And there is one more short question. So is there a wait list? I think yes. You
Waiting,
mean
waiting list?
waiting list? I
Waiting
guess
list. For the IVF treatment in our clinic, there is no waiting list at all. The patient
wait list.
can start whenever she wants to
Mhm.
do it. Yeah.
And is it regarding egg donation by any chance, Pauline? If that's the case, how does it look when it comes to egg donation treatment?
Well, when it's egg donation, it takes like 2 to 3 months, depending on the patient maximum, to them to transfer for us. Between we select the donor and then we do the stimulation of the donor, we prepare the patient's uterus, and so it will be between 2 and 3 months.
Okay. Again, thank you for the clarification. One more follow up. So I guess the best thing to do is contact the team
Mhm.
directly regarding the costs of the treatment. Okay, thank you. And Vanessa, one more question. Has one more question. Sorry. So, do Tambre have a genetic laboratory to provide PGT results to do the transfer on day 6?
Yeah, it's possible to do what we call the 24 hours PETA, in which we do the biopsy on day 5 and we do the embryo transfer on day 6. So it's true that we prefer not doing it. The main reason is sometimes, doing the embryo transfer on day 6 may have an impact in terms of the window of implantation, but it's doable. I mean, so some patients want to do it and we do it. Okay, so if we can choose, I would suggest not doing it because of the window of implantation issues, but it's also doable and we can do it for sure.
Okay, brilliant. Again, thank you so much. And thank you for the reassurance here as well. I believe it helped. So let me have a look. I don't see more questions. So it looks like we will be finishing for today. But as I've already mentioned, if you wish to ask some more questions, you can still do it or simply get in touch with Clinica Tambre's team. I'm sure they will be happy to help you. But also, as always, we will be back with more webinars, and I guess we will be finishing. So thank you everyone for joining again. Thank you for your questions, and I hope that it was useful. I do believe it was very useful for you, and I'm really looking forward to some more events. More topics definitely are coming up, and more fertility specialists and more guests are going to be here. So thanks a lot for coming, and so thank you for your congratulations for our 500th webinar. As I've mentioned, it wouldn't be possible if you didn't come here and didn't support us as well. Dr. Marban, always a pleasure to have you. Thank you for sharing your experience. Thank you for being with us today as well. This is definitely a special event and evening for my IVF fences. So before we finish, anything else you wish to add?
Just to say, thank you and to congratulate you for your 500th webinar. And as usual, it has been a pleasure for me to have the chance of being with you tonight. So, well, I hope that, all the attendants that have been with us today had the chance of listening a little bit about science. And I hope that, well, we have been able to answer all their questions. I'm so happy to be in here. Thank you, Caroline, for inviting me.
Thank you so much for joining. And I know it's not our final webinar with you as well. So I'm really looking forward to some more events, of course, as always. And just so you know, we will be back actually on Tuesday, 7th of November. We will discuss PGTA. So if this is something that you wish to learn more about, you can join us at 7 p.m. UK time. We will be back with Dr. Vladimiro Silva. So if you have questions on PGTA, you know what to do. Just join us and you will be able to do it. Thank you so much. It's been great to have you all here today. Thank you from our entire team. And well, till our next event, Dr. Marban, always a pleasure. Speak to you soon. Take
Likewise.
care and have a lovely evening. See you soon. Bye.
See you soon. Take care. Bye bye.